2005 in neurosurgery, and since then this been more widely used for the treatment of medial artery aneurysms. This technique was ideal for this patient. It was a 53-year-old woman with polycystic kidney disease and a multi-lobed aneurysm measuring 5 millimeters. The patient also had a family history of subarachnoid hemorrhage, and she clearly felt quite concerned about having this aneurysm, and the options of open surgery, of course, were discussed with her, but her preference was to use an endovascular treatment. The anatomy of this bifurcation has to be clearly defined, and the 3D angiography is very important on this assessment. Because of the complexity of this anatomy, we decided to use a ProSelect Plus and a synchro wire to catheterize, and perhaps this is one of the most important tips of this technique is always consider to catheterize first the most challenging vessel of the bifurcation. In this case, we felt to be the superior branch of the medial artery bifurcation. We also used a 6 French neuron guide catheter over Select to catheterize the internal carotid artery. The patient was fully heparinized with an ACT of 250, as well as the PRU and ARU levels were therapeutic. We gently using the 3D roadmap technique allows us to have on the left side of our monitor a fluoroscopic view and a better appreciation of the device performance and through the anatomy, and on the right side you can see that you can choose the angle of the anatomy without having to do constant number of road maps as you're trying to find this very challenging anatomy, and many times you may have to change the position of your tube as you move into this anatomy, so having the 3D roadmap gives you a lot of flexibility. This is an important aspect here. We have to do a roadmap to look at the distal anatomy. As we position the 14 wire, we want to get significant purchase into the distal vessel, but be very careful about not perforating the small vessels as the anatomy gets more distal. But also you want to position the wire, the transition portion between soft and more sturdy segment of the wire, right at the bifurcation, so you can see how the microcatheter goes through the aneurysm area without bucking into the aneurysm, and this position is also very crucial to have a distal placement of the microcatheter, so that when you navigate your stent into this location, you will not have any chance of losing your catheter position. So in this case, we chose the shortest enterprise stent available. One could use an enterprise without the distal tip. In this case, we have one with distal tip. The more distal we go into the anatomy, the use of stents or delivery systems that have no distal wire will be more beneficial. In this case, we felt comfortable we had enough of a landing area for a wire. And you can see here that the 3D roadmap is deformed, but I still have a good sense, and I prefer to have on the left side the fluoroscopic view to see exactly where the device is being deployed. With this fluoroscopy, I had the comfort that even though I had distortion in the 3D, the landing area for the neck of the aneurysm was there's significant mismatch between the size of the stent and the neck of the aneurysm, that I felt comfortable using bone landmarks as well as my 3D roadmap to deploy the first stent. Now, once you deploy the stent, you see that we were careful to have a very good purchase of the middle cerebral artery M2 segment and very little on the M1 segment. That was done to avoid placing multiple devices for a long segment of overlapping into the M1. Once we deploy the first, the microcatheter remains in position, and you use the Synchro 14 wire now to catheterize the second branch of the bifurcation. And in this case, this is an extremely important part. It's just it has to be done without moving the first device. So once we get the wire across the cells of the first stent into the M2 segment to be stented, we want to obtain in the same way a distal position of the wire, so that that gives a better way to direct the microcatheter through that cell. And this is a very important part. As you can see here, one has to magnify and see very well that catheter passing through the cell. You see that there's going to be a little bump as it goes through that cell, but I'm adjusting the wire and the microcatheter position to find the soft spot to go right through that cell of the stent. And this has to be done without moving the first stent. You saw just there, we were able to find a little space, and then you pass the microcatheter through that cell without moving the first stent. Now, as we deploy the second device, we are careful to obtain, again, good distal purchase, but then very little into the M1, so you don't have a lot of overlapping devices into the M1 segment, but you have a very comfortable protection of the neck of the aneurysm. And the Y, in this case, we chose the same size of device as the first one, so you have two closed cell designs, stents measuring 14 millimeter each, so that you have the shortest segment of metal possible into the M2 and M1 bifurcation. And once you have this stent deployed, sometimes the wire can get caught. You can see right there that you can have a little bit of resistance to pull the wire back of the delivery system of the stent. This has to be done very careful, so you may have to push forward and then back so that you're able to release the wire from the two stents. But the last thing you want to do here is to move the Y stent construct, because it gets caught into your the bumpers of your delivery system. We always analyze the 3D again after the placement of the construct. It's likely that you may need another view to place the coils into this. And I think what's been very helpful to us is to obtain now a new acquisition using the Siemens DynaCT VOI technique, which is a collimation from top to bottom and side to side to decrease the dose of radiation that we do in this next spin. But this type of acquisition will allow us then to form a model of the stents that were deployed. So you're not doing a virtual stent, you're actually using the real Y stent construct to then overlay in your anatomy as you advance a microcatheter through the Y stent to get access to the aneurysm. One can argue that it would be okay also to place the microcatheter in parallel, but I think it's quite busy when you have to construct a Y and have a microcatheter into the aneurysm position, especially on the small aneurysms like this one. So I think that this overlay technique allows you to have a nice idea of where the transition between the parent vessel that you have created with the Y construct and the aneurysm is. And in this case, we have to place very little wire in the aneurysm because this is a multi-lobe aneurysm. The daughter sacs are extremely high risk for possible rupture, so one has to be able to fade in and out the overlay. As you can see on the right side, we're able then to visualize the device as well as visualize the boundaries of this anatomy that is quite complex. But the moment that we're comfortable that the microcatheter is in position, we're able then to confirm that in multiple views and position the our tube into the best angle possible to start the coiling procedure. And the use of single plane and these techniques of overlaying as well as the 3D roadmap is allowing us to use much less contrast as well as radiation during this procedure. In a patient with a polycystic kidney disease, this is quite important. So in this case, we're placing the first coil. I, in general, tend to go with very soft. This is an ultra soft 360 coil, and it's undersized. And I think that the idea of undersizing is we have significant protection at the neck of the aneurysm. I want this to be as easy as possible to place these coils without a lot of pushback of having to have the microcatheter go in and out of the parent vessel. I think that it's very important now that once you got access to the aneurysm, that your microcatheter stays there and you're able then to place all the coils inside of the aneurysm without having to manipulate the catheter too many times. Unfortunately, in this case, my first coil was not able to completely cover all the neck of the aneurysm, or rather was not able to cover all the lobes of the aneurysm. So I had to reposition the tip of the microcatheter to go into the inferior portion of this aneurysm, and then we place 2 more target coils on that location. And this was done in the best way possible I can think of is to use softer coils. And the debate is if you have 2 stents across the neck of the aneurysm in a Y configuration, especially closed cell stents, if it's needed to have a complete occlusion in the aneurysm. Our feeling is that we'd like to do the best coiling we can do and still have the stents across. So you have the immediate sealing or closure of the aneurysm, as well as the Y stent adding the long-term durability of this treatment. So it's a combination of having an initial closure of the aneurysm as well as a reconstruction of the parent vessels that will be provide us the durability of this treatment. Once we were satisfied with the closure of the aneurysm, we proceed to then basically check the under. This is a very challenging portion of the procedure, like when is enough to coil this, but we tend to do this under a blank roadmap, as you can see here, and you analyze that every one of the segments of the aneurysm is at least being filled by the coil, and when this is the final angiographic view, confirming the impression that we had a good coil mass and the reconstruction of the parent vessels. And here you can see the arrows pointed to stents as well as the coil mass. This patient did very well through the procedure. She had no change in her neurologic exam. She was discharged the next day and had a successful recovery.